class. In my today's class, I'm going to discuss a topic which is a little different, but it is very useful. So I'll discuss about the management of tuberculosis in spatial situation, that is in case of abnormal liver function test. So if there is abnormality in the liver function test, there is elevated liver enzymes, and how we are going to treat a patient of tuberculosis, because most of the anti-tubercular drugs are hepatotoxic. So it is very important to know the management of tuberculosis in certain spatial situation. In my other classes, I am going to discuss about other spatial situations where we need to modify the anti-tubercular regimen. So in this class, it is about the abnormal liver function test. Now, there can be two situations of abnormal liver function test. In first scenario, the liver function test may be abnormal from the baseline itself, and in the second scenario, the liver function test may be deranged after starting the anti-tubercular regimen. So in this flowchart, let's see about the management of tuberculosis if the LFT is deranged from the baseline. So before the starting of anti-tubercular drugs, we need to find out how is the liver function test in the baseline, and for that we need to do a liver function test. So if the liver function test is normal and there is no history of liver diseases and the patient is non-alcoholic, then repeat LFT is not required till the patient is symptomatic of hepatitis. Now, what are the symptoms or signs of hepatitis? There may be nausea, vomiting, abdominal tenderness, particularly tenderness in the right upper abdomen. There may be presence of jaundice and hepatic enlargement. So these are few signs of hepatitis. So I said, if the liver function test is normal at baseline and there is no history of liver disease and the patient is not alcoholic, so in that case, we may not repeat the LFT until the patient is symptomatic of hepatitis. Now, if the LFT is normal at baseline, but the patient's age is more than 35 years, patient has history of liver disease and patient is alcoholic. In these situations, we need to follow up with liver function test every 2 weeks for first 2 months and then monthly. So this is important. If the patient has these conditions, then we need to monitor the LFT every 2 weeks for first 2 months and then every monthly. If the LFT itself is abnormal at the baseline itself, so what we need to do, if the enzymes, if the transaminases, that is liver enzymes, if the transaminases is less than 3 times of the upper limit of the normal, ULN stands for upper limit of normal. So if it is less than 3 times raised, but it is less than 3 times of the upper limit of normal, then we need to start the treatment and monitor the patient. How do we monitor the patient? We do LFT, frequently, probably we need to do every 2 weeks. Now, if the level of transaminases is raised and it is more than or equal to 3 times of the upper limit of normal, it was below 3 times, now it is above or equal to 3 times of the upper limit of normal, we need to plan alternate treatment, because we will not be able to use the first line anti-tubercular agents because they are quite hepatotoxic. So if there is no alternative medicine available, then we need to start with EMB and streptomycin, that is ethambutol and streptomycin. So this is about the protocol of how do we manage a case of tuberculosis, or how do we prescribe the anti-tubercular regimen in a patient with abnormal LFT at baseline. Now look at the next scenario. As I said, the next scenario or the other scenario may be the LFT becomes abnormal after starting of anti-tubercular regimen, anti-tubercular treatment or anti-tubercular drugs. So after starting ATT, if the LFT becomes abnormal, we need to again see the transaminases, that is ALT and AST. Okay, alanine transaminase and aspartate transaminase. If the level of this transaminases is below 3 times the upper limit of normal, then again you can do monitoring of LFT every 2 weeks for first 2 months and then monthly, like before I said in the previous slide. If ALT AST level is raised and it is in between 3 times to 5 times of the upper limit of normal, but the patient is asymptomatic, then fortnightly follow-up and monitoring for liver enzymes and symptoms of hepatic involvement, okay, symptoms of hepatitis. Now, if the patient is symptomatic, then we need to withhold all hepatotoxic drugs. If patient is on continuation phase, then we need to replace isoniazid and rifampicin with ethambutol, aminoglycosides and fluoroquinolones till LFT returns to 2 times the upper limit of normal. When the LFT returns to 2 times or below 2 times of the upper limit of normal, we can re-challenge the patient with isoniazid and rifampicin. Okay. Replace isoniazid or rifampicin with ethambutol, aminoglycosides permanently and change regimen accordingly. If again the patient develops hepatitis, the patient becomes very much symptomatic with the re-challenge. Okay. Now, if ALT or AST is more than 5 times of the upper limit of normal, then what we need to do? Again, we need to withhold all the hepatotoxic drugs. If LFT are high, hold drugs till it returns to 2 times of the upper limit of normal. Okay. Then, if the patient is asymptomatic, patient becomes asymptomatic, restart the drugs, okay, as per the reintroduction. Restart the drug as per reintroduction and do the management. Now, how do we reintroduce or re-challenge? That we need to know. So after resolution of symptoms and LFT returns to less than or 2 times of the upper limit of normal, we need to reintroduce one drug at a time. We need to start with isoniazid. If patient was asymptomatic for 3 days, we need to add a rifampicin. Okay, we start with isoniazid, then we add on rifampicin if the patient is asymptomatic for 3 days after starting of isoniazid. If patient is very asymptomatic for next 3 days after starting of rifampicin, then add the next drug and so on. Okay, if symptoms recur, replace the responsible drug. Okay, we should not be reintroducing pyrazinamide as much as possible, because pyrazinamide is probably the most hepatotoxic anti-tubercular drug. So once the patient's LFT becomes deranged, we should not be using pyrazinamide anymore, okay, as much as possible. So the reintroduction strategy is you start with one drug, wait for next 3 days. If there is no symptoms, then add on the next drug. First start with isoniazid, okay, INH, then you give rifampicin, and then you can add on, but never give pyrazinamide. Now, if the patient's hepatic condition is not suitable, continue on ethambutol and streptomycin. Means we may not re-challenge. If the hepatic condition is not suitable, we need to continue with ethambutol and streptomycin. Okay. Then if no alternative medicine, we need to continue with the drugs as I mentioned. So this is about the managing a case of drug-induced or antitubercular drug-induced hepatitis. How we are going to deal with a patient who has developed abnormalities in the liver function test after we have started the antitubercular treatment. Okay. So I hope this class was helpful, because this is very, very important practically. When we treat the patient, we need to do a baseline LFT, and then we need to monitor the patient for symptoms of hepatitis. We need to monitor the patients with liver function test as per the protocol just now I mentioned. Thank you so much for attending my class.